happy to have you along for what I know will be valuable time spent for either you or someone in your life that you know and love as we discuss how to prepare for a positive caesarean birth. Caesarean birth accounts for close to 30% of births in Australia, and we're big believers in preparing for them, so you can have as positive and empowering experience as possible. So I'm Rebecca McQueen from Birth Sense Australia, and today I'm joined by obstetrician and gynaecologist Dr Vanessa King, whose passion is caring for women before, during and after their pregnancies, as well as managing gynaecological problems throughout a woman's life. Having grown up in country Victoria, Vanessa loves the practical hands-on aspects of obstetrics and gynaecology and enjoys being able to care for women at what is a really important time of their lives. And I want to say, welcome, Dr. King.
Thank you, Beck. Thank you for having me. It's a bit fun to do this.
It is a bit fun. I think that we're all getting more and more used to doing Zooms and webinars. And it's such a good way to get lots of information out to as many people as we can. And I'm just really grateful to have you along so you can share all your experience and your wisdom for the women out there who may be having a planned caesarean, but also the women who are listening who mightn't be planning to have one and may, because of circumstances, end up having one. So this is a discussion for everyone. So thank you.
No, pleasure.
I always love to share the rich experience of my guest experts before getting into a good discussion. So let me do that just now. So after graduating from Monash University, Dr. King has worked in various settings in Australia and internationally. And she now works in a practice called Melbourne City Obstetrics and Gynaecology with 4 other female obstetricians. Dr. King is affiliated with St Vincent's Private in Melbourne and Epworth Freemasons Hospitals, as well as having a public gynaecology appointment at the Mercy Hospital for Women here in what is sunny Melbourne today. Vanessa's obstetric practice includes the management of low and high-risk pregnancies, managing multiple pregnancies, and she has a keen interest in fertility. So much so that she's just started her IVF training with Monash IVF. So for various reasons, many women will need a Dr. King on their team at some stage in their life. And today we're going to be focusing on the women here in Australia and maybe around the world that are preparing to have a caesarean birth. So Dr. King, what are the reasons some women need a caesarean birth for the birth of their babies?
I think it's probably good to divide it into elective and emergency because it can be a little bit different. So in terms of elective caesarean sections, probably the main reasons would be if a baby's breech. A lot of women will have a caesarean for that reason. A low placenta or placenta previa, a really big baby where after discussion with their obstetrician, it's decided not to try for vaginal delivery because it's quite big. The other end of the spectrum is little babies that we don't think will handle labour. So we think it's better to do a caesarean section on those. Twins, multiple pregnancy, probably the majority these days is via caesarean section, but you can have twins vaginally as well. If someone's had a Caesar before, they may elect to have a caesarean the second time, or if a mother wants it. Emergency Caesars, so that's a bit different. Someone's trying for vaginal delivery. And the 2 biggest reasons would be if baby's not happy and not coping, which we can tell with their heart rate patterns, or trying for labour, things just aren't progressing even though we use a few tricks that we've got up our sleeve. And baby's just, it's either not dilating or they're stuck and not going to come out that way.
Yes, so it is. And do you have a bit of a feeling for how, of all the caesareans that you do, how many would be elective versus emergency?
Yeah. So probably about 2/3 of caesareans we do are elective and about 1/3 are emergency. So to get a bit of an idea in terms of emergency caesareans, for those women that go into labour, about 15% will end up with a caesarean. So certainly vast majority will get a vaginal delivery and most of those will be a normal delivery. There's a certain percentage that will be assisted in terms of a forceps or a ventouse, and then about 15% will need a caesarean section.
Okay. So how long does a caesarean take?
It's I often talk about from when you get to theatre to when you leave the theatre, and that's probably about an hour. The actual caesarean operation probably only takes about half an hour, but you can get into theatre. You often got to meet the anaesthetist. If it's an elective or they don't have an epidural in, they'll need to have the spinal anaesthetic put in. We get everything ready, do the caesarean section, and there's probably about 10 minutes afterwards just to sort of get mum off the table onto a bed, clean things up. So probably from into theatre out to theatre about an hour.
Okay. And that recovery period then, I suppose it's different for everyone depending on how they're recovering. If everything's flowing along, fairly smoothly, how long do women spend in recovery?
So after they go out of theatre, they go into the recovery room, and that's probably about an hour. Majority of the times, especially all the time when it's elective, and most of the time when it's an emergency, the dad and baby and midwife will be in recovery with the mum, which is really lovely. Certainly in an emergency, the maternity staff really try to have a midwife available, if possible, to be with, and that means that the baby can stay with mum. If the birth suite is really busy and there's not a midwife available, particularly after hours or overnight, then it's not always the case, unfortunately. But usually it's only about an hour that mum's there. If baby can't stay with mum, then dad will stay with baby and often just pop down to nursery so that they've got staff there to sort of keep an eye on baby. And then after mum's finished during recovery, after about an hour, she'll go back down to the ward and baby will come to mum's room there.
Okay. I think it's often handy for people to understand those timelines, and it's just about having that knowledge so it takes some of the anxiety away. So along those lines, tell us about where the cut is actually made.
Yeah. So it's actually quite low down. I think sometimes further down than a lot of women think. So it's actually sort of within your undies. So your undies would cover it up. In terms of how big it is, we've got to be able to get a baby's head out, which is, so it's often, I often go like that. So it's often about that long, which is probably about, I did measure it, it's about 12 centimetres, all right? Because often a baby's head's round and the diameter of a baby's head's often 9 to 10 centimetres.
Okay. So, and there'll be stitches. Do those stitches always dissolve?
That depends on the surgeon. So there are stitches that dissolve, and that's the ones, I do use ones that dissolve. But some surgeons prefer to use what's called a nylon stitch, and that normally comes out on the day that a woman goes home, about day 5 or 6. Some also use staples. There are staples that dissolve. There's not very many that would use staples that have to be taken out.
Okay.
And the other thing I do like to use as well is the dressing's important as well as the stitches. So the dressing that I use at the moment is a really good one in terms of scarring, I think. It's one that, it's a bit of a tape and glue, which sounds a bit domestic, but it's a great tape, and then it's glue, a bit like if a little, kids or anything do a little cut and they put glue in that cut instead of a stitch. So it's a bit like that, and it just keeps the wound together, and I reckon it makes just a bit thinner wounds when I see them at 6 weeks, and I actually get them to keep that dressing on hopefully for the full 6 weeks, because it takes the pressure off the wound and often gives you a little bit better wound.
Okay, that's interesting. They're always coming out with
always new stuff. Yeah. And everyone will use a different thing. It doesn't mean it's any better or worse. It's just surgeon preference as to what they want to use.
Okay. So with regards to women, I think sometimes there can be confusion around, do you have an epidural or do you have a spinal? So can you just talk us through those differences?
The reason there's confusion is because you can have either. All right, so for an elective procedure, or if someone's in labour and then without an epidural and they go to theatre, they'll have a spinal anaesthetic. Okay, so a spinal anaesthetic is a one-off shot. So it's just a single injection into the back. There's nothing left in the back, and it keeps women numb for 2 to 3 hours. If someone already is in labour and has an epidural, then that epidural has a little catheter that's near the spine that's giving a continuous infusion through labour, because labour often lasts for more than 2 or 3 hours, so you need something that lasts longer. If they've already got that in and it's working well, the anaesthetist will just inject more local anaesthetic into that we call it tops you up. So it sort of makes the block more dense, so it nearly takes away all that feeling, the pain feeling.
Okay, there you go. That's why there's confusion, because they can both be used.
Yeah, exactly.
Yeah. Okay. So these have been really great tips. What do you think, if I was just to throw it out there in a more general fashion, the things that parents need to understand before they go in for their caesarean birth that you think are handy?
Yeah. I think one of the things that people are sometimes surprised at is theatre's quite cold. And the reason it's cold is that when I then do the surgery, I've got to put a gown on, I've got to put gloves on, I've got to put a mask on, and that sort of is a bit claustrophobic and heats you up. So it's a little bit to keep the surgeon's temperature at a good level. So that's a bit why theatre's a bit on the chilly side. Why that's, I sort of warn people, is that part of the reason when babies are born that we sort of wrap them up nice and warm is that babies are wet and they can quickly get cold. Their temperature regulation system's not that great. So that's why we've got to keep babies nice and warm. So when babies are born, I give the baby to the paediatrician, and they often give a sort of kiss and a cuddle and a touch. But because theatre's cold, most of the time they'll take them over to the cot where it's nice and warm and wrap them up, okay? And then bring them back over to mum for a fabulous long cuddle. All right, so that's one of the things, that theatre's a bit chill. The other thing is that theatre's quite crowded. There's actually lots of people in theatre. All right, so in terms of naming them all, there is an anaesthetist, who's obviously essential. There's an anaesthetic nurse who helps them and does things for them. There's myself. I have an assistant who helps me do the surgery. There's a scrub nurse who's scrubbed in, giving me instruments and helping me. There's a scout nurse that's getting her things if she needs them. There's the paediatrician. There's the midwife, and there's often a theatre tech. So I think we get up to about 11 people as a minimum. And yeah, so it's quite crowded. Yeah.
Yeah. One thing that some women, and I've got a couple of questions coming through too that I'm wondering, we might do the questions just before we wrap up, if that's okay. So one thing that a lot of women don't realise too is that they'll need a catheter, or sometimes need a catheter, or is it, I would imagine it's always need a catheter.
Yeah. And there's 2 reasons for needing a catheter. One is that we've blocked everything. So even if you wanted to wee with either a spinal or an epidural, you wouldn't be able to. So then there's the risk of the bladder filling up and getting bigger and bigger. So that's not good for the bladder. That's one reason. The other reason is that the bladder sits right in front of the uterus, and we only go just above that bladder in terms of where we do our cut on the uterus. So we've actually got to push that bladder down a little bit off the front of the uterus to do the cut where we want to, low down on the uterus. So we want that bladder nice and small, so there's less chance of us causing any damage to that bladder and pushing it out of our way so we're not working near it.
Okay. So, and when does that get popped in, the catheter, and when does it come out generally? Yeah,
so if someone's already got an epidural in labour ward, the catheter will be put in after the epidural's in. So they're nice and numb, and the same with the spinal anaesthetic in theatre. So the spinal gets put in usually with the woman sitting up. It works fairly quickly, the spinal. So as soon as that's in, we lie someone down, and you start to get numb very quickly. So by the time we then get organised to pop legs up and pop the catheter in, you can't feel it going in.
Yeah, okay, great.
Yeah. And in terms of it coming out, because that's the opposite end. So I often, especially for caesareans that are done in the morning, which most elective Caesars often are in hospitals, if the woman's happy and comfortable, I'll actually try and get it out that evening to get them up and moving. Otherwise, it comes out the following morning.
Okay, and that's a very simple procedure that takes no time
Like,
at all, and there's rarely any sensation.
Yeah, it's just a sort of funny, you know, almost, you know, I often equate things to Band-Aids. It's just a quick, is, you know, out, feels a bit funny, and then it's done.
Yeah, okay. So, again, some questions are coming through. I've just had a question that's relevant to what we're talking about now, in that how many birth partners are allowed in theatre? Thank you for that question.
Just one.
Yeah, okay.
Generally just one.
Yeah. And that would be because it's infection control and it's harder to...
Bit, but partly also because, as I said, theatre is quite crowded and everyone's doing a job. And if we then put more people in that sort of aren't so used to theatre, it does become a few too many. Yeah, a few too many people. So generally it's just the one person in there. Yep.
And if there are any other birth partners that are involved, they could definitely be there in the room when the woman, like before and after, and can still be involved, but one person in theatre.
One person in theatre, yeah. Okay. Yeah, and I think that's pretty much everywhere. I sort of have never worked anywhere that it's sort of, yeah. Okay. There might be, you know, occasional, exceptional circumstances or something, so you can always ask, but yeah, most of the time it is just one.
So tell us about the other sensations or smells or things like that that women can expect for their caesarean birth. Yeah.
So one thing, and that's, I sort of mentioned it before, and it's always hard to get back on topic, isn't it? In terms of that, the epidural and the spinal means there's no pain. Yeah. And we always check before we start a caesarean section. We actually, often without you noticing, do a little pinch on the skin to sort of check that everything is numb. And then needs, just before we even do that, sort of checks with sort of temperature sensation that the epidural or spinal is working adequately before we start. But what the epidural and spinal cover is pain sensation and temperature sensation. So it actually doesn't stop this movement sensation. So you will still feel us doing putting the prep on, putting the antiseptic on your tummy. You'll feel us doing that, but it's not cold. You'll feel us doing a bit of movement as well, but it doesn't hurt. So I'm sure it's a bit of an unnerving sensation sometimes, but the main thing is it doesn't hurt. One other thing that people often will feel is when we're delivering the baby, often the assistant's job is to put a bit of pressure on the top to give us a bit of extra oomph to deliver baby. So I'll sometimes feel that bit of pressure pushing down as well. In terms of smells you mentioned, the main thing can be, and I try and minimise it as much as I can, is we do use diathermy. And two reasons we use diathermy. One is sometimes to cut the tissues to get into the abdomen. The other is to cauterise if something's bleeding. The hospitals I work at now do have an extractor attached to that instrument to take away the sort of smoke and smell that's generated. So I'm finding it's not as bad, but it can be a little bit odd because it does smell a bit like burning tissue because that's what's happening. But it is there for a reason, to mainly to stop bleeding. Yeah,
that heat seals off the vessels, and again, it's about knowing that there's nothing wrong, that's very standard, all's well, and I think that gives women a lot of reassurance to have that information. So are there any other, I once had a woman say to me, it felt a bit like someone was washing dishes in her stomach, and I thought, that's an interesting thing.
Often we say, the other thing isn't the noise actually, so, and the noise of the suction trying to suck up some of the amniotic fluid. So when we open the uterus, so we do a cut on the uterus and open it up, in doing that we break the membranes and break the waters. And with some women, there's a lot of fluid comes out. So we're trying to sort of suction that up so it goes away from our working field. And we often say it sounds like a cappuccino machine. Is the other thing. So, and often we say to people, when you hear that cappuccino machine, that's baby's, about to be born. So, yeah, and it probably can. It's always hard to know how much women are listening and things like that. And but it's an interesting comment that someone's made that's what they thought it sounded like.
I love that. Well, I think we're all pretty familiar with that sound, the cappuccino.
Yeah, exactly.
Just because we're talking about the sensations and of cesarean, and I've had another question. Is a spinal or an epidural more effective? She's particular lady's been hearing about some epidurals that have failed. Do you have any sense of that?
Yeah. So there's always a risk that an initial epidural or spinal doesn't work, and that's why anaesthetists will be. They often get a really little cold frozen thing and sort of check temperature here, and then just check temperature and see where the block is, because it's the same fibres that take pain take temperature. So that's why they're checking temperature, because it's then indicate where the pain level is. If an epidural or spinal doesn't work the first time, then they will try again, and hopefully get it into the right, because it has to get into a particular space in the spinal cord.
Yeah.
The worst case that if, for whatever reason, they're unable to get a good spinal anaesthetic, the only other way that we can do the cesarean is with the general anaesthetic, okay, which we know is not ideal for the woman and partner. It doesn't happen very much at all.
Yeah.
And the only other time we use general anaesthetic is if we're very concerned if someone's bleeding a lot and we're worried about sort of blood loss and that we might need to do anything more than just the cesarean. Yeah.
I know a general is not recommended, but for any woman who's ever had a history of trauma, is that a time where a general might be considered?
It might be considered, yeah. So there's a few reasons why we prefer the regional anaesthetic. One is obviously it means mum, dad or partner can be involved in the birth process, which is really important. The other is it actually is a little bit safer, because in terms of general anaesthetic, you need to put a tube down the throat, and in pregnancy things are a bit more swollen. So occasionally it can be a little bit more difficult to intubate a patient. And the last thing is that a general anaesthetic, a little bit of it can get through to the baby. And so sometimes babies at general anaesthetic can just come out a bit sort of floppier and a bit more stunned, but they're usually always fine. But for that reason, once the general's done, we try and get the baby out fairly quickly, so to reduce that chance of a baby being a bit stunned.
Yeah.
Yes. But if a general anaesthetic's needed, it's needed. Yeah.
Yeah, but it's really rare.
Yeah.
So, what's my next question that we've got some more coming through, and thank you so much for people that are asking. Can you see the questions yourself?
No, I'll probably need to click on something there.
Yeah, there'll be a little Q&A.
Yeah. Got it?
Yeah. So as we're going along, you can see those questions yourself, and if it ties in with what you're talking about, you can draw on that, and we'll get to the questions at the end that we haven't got to. So I guess the question I'm asking are what are the risks of major complications with the cesarean birth? Yeah,
really, really, really low. In terms, there's two things. There's the anaesthetic, and the incidence of a major complication from the anaesthetic is extremely low. You'd probably have more of a chance of being involved in a significant car accident than having anything happen at a spinal anaesthetic. There are some more minor complications that can be temporary, and the commonest one is where they call it a dural tap, and you can end up with a significant headache afterwards. And if that happens, then they can then do something to try and sort of patch up the little leak that's happening. So that doesn't happen very much, but every so often it does. But that's what we more call a minor complication. In terms of the surgery part of it, again, very low complication rate. And I sort of talk to women about the chance of bleeding and needing blood transfusions. But particularly in an elective cesarean section, it's actually less chance than if you have a vaginal delivery. The higher chance, though, is if you have an emergency cesarean. So that's one. Infection risk is really low, and we actually give some antibiotics during the caesarean to reduce the chance of infection with the mum. Damage to other things in your tummy is also really rare. Bladder, as I mentioned before, if we do damage the bladder, and by that I mean put a hole in it, which sounds awful, but it's actually very easy to repair a bladder. And then we leave the catheter in for longer to let it heal for about sort of 5 to 7 days. And there's usually no long-term problems from that. And the last one that I talk to women about is clots in the leg, so DVT. And again, to try and prevent that, we put really tight stockings on. We give little injections once a day until you go home to prevent clot, and get you up and about. So that's why it's actually been shown in a bit more recent evidence that getting up and moving is actually good for pain. So it's good for pain, it's good for preventing clot. So that's why if women are comfortable enough, I'll encourage them to get up that evening out of bed. Otherwise, it's definitely up the next morning and moving around a little bit.
It's interesting about getting up earlier is good for pain.
Yeah.
We've got some questions again coming in around pain. So one question is a sedative not usually administered prior to the spinal?
No, because it's not really necessary. Sometimes the worst part of the spinal anaesthetic is actually the little bit of local anaesthetic they put around the skin, because that stings a little bit. But once that's in, things are pretty numb. They'll often feel a bit of pressure and pushing, but it doesn't hurt.
Okay.
And we always warn people that the antiseptic that's put on the back is really cold. So sometimes that can be just to warn people, otherwise they sort of get a jump in fright when the cold anaesthetic's put on. But no sedation, because we want you to be awake and present in the caesarean, so we don't want to give any sedation.
Yeah, that's right. And when your baby's born too, you want to be present and doing everything you can to be bonding rather than a little bit groggy.
Absolutely. And I mean, in terms of, to give it an idea of timing as well, from when the spinal anaesthetic goes in and then the catheter goes in, and then we quite quickly prep the tummy and put sterile drapes and things on, and then baby's out within 10 minutes. So it's quite quick till you get bubs. Which is quite good, because especially for those women that, are a bit anxious and, not coping that well, because it's an odd environment and sometimes an odd thing to have done, because you're sort of centre in the theatre, you're lying down, you can't move because your legs are numb. But I find often once baby's out, it's a completely different feel for the woman, because they've got a fabulous distraction, and they often sort of feel a lot better once baby's out. So that's actually the quick bit, is getting baby out. And then it takes about 20 minutes then for us to put everything back together. And in that time, they're often having a good cuddle with baby. So they've sort of got that fabulous distraction.
And I'd imagine they've got their baby, there's still that feeling maybe of a bit of tugging and pulling, but it shouldn't be painful. And if it is, say something.
Absolutely, yeah.
You would have said something before then, I'm sure, but that's still that pulling and moving around can still be occurring.
Yeah.
Okay. So while we're talking about pain relief, what's the pain relief that is usually provided? Ask another attendee post-surgery, and are there alternatives to morphine?
Look, generally I leave the units just a bit in charge of this, but look, the commonest regime would be an underlying regular Panadol and an anti-inflammatory regularly, and then on top of that something stronger, which the commonest is endone. Usually only use morphine if that's sort of not giving adequate pain relief. So, as in a sort of, one-off shot of morphine. So it's actually more endone that's used initially. And then we tend to move down to tramadol, which is sort of in between sort of Pandine Forte and endone. So it's sort of that step down. Sometimes doesn't make you quite as groggy. So that would be the commonest regime.
People often underrate the background Panadol, the 4 to 6 hourly Panadol, but it gives that fantastic background relief, doesn't it, that you can step down and be covered?
Absolutely. It's really important. Yeah. And it's often just that first 24 hours that people feel a bit fuzzy in the head. from the analgesia, because then the subsequent 24 hours I don't need quite as much. It's sometimes a difficult balance between getting adequate pain relief and that fuzziness in the head. Yeah, so we do understand that. What was the other thing I was going to say? I was about to say something that I forgot. Anyway.
Because I keep throwing you off with the questions that are coming in. Sorry.
Yeah, right. Oh, that's what I was going to say. So in terms of the pain relief, we sort of want it that when you're sort of lying still in bed, that it doesn't hurt, but you will feel it and have a little bit of pain when you get up and move around, and that's normal. Yeah.
So, that getting out of bed, sometimes women can feel nervous and maybe reluctant to do.
Yeah.
But what you've said before about it's been shown that getting up and moving around is better for your pain, that might be some motivation to go, okay, I know this is for the greater good, the longer haul of the recovery. So that's really good information too.
Yeah.
Thank you.
And I think extending on that, because our population is younger and generally fairly fit, I find majority of women say, I recovered better than I thought I was going to. I think there's sometimes a message out there that Caesarean, you'll be, stuck, you won't be able to move, and there's sort of a lot of negative stuff about recovery post-Caesarean. So I think majority of women find it's not as bad as they think it's going to
be. Yeah, the lead up can be more anxiety producing than the event itself.
Yeah.
So again, we've got some more questions coming through. Thank you. Keep them coming, and we'll get to them as we can. I know that Dr. King has got some more patients to see, so we're going to keep going. I want to talk to you a little bit about immediate skin-to-skin contact, because that's been getting a lot of research behind it about the benefits. How does skin-to-skin, immediate skin-to-skin, and a Caesarean birth work together?
Yeah. So we sort of touched on a little bit before in terms of what happens. So when baby comes out, and I do that quite slowly, because often the anaesthetist or the anaesthetic nurse or midwife or someone will have taken the partner's camera, and you actually get some fabulous photos at Caesarean section, I think. A lot more than you do in vaginal delivery, because everyone's, there's other stuff happening. But you often get really good photos, and I just take baby out nice and slowly. And I find that the theatre lights give fabulous lighting just on baby as well. So you can actually end up with some really moody, fantastic looking photos.
That one you posted on Instagram was fantastic.
It was good, wasn't it? Yeah. So I'll get baby out, and then we'll usually drop the curtain and show sort of mum and dad baby, and often let them see if it's a boy or a girl, if they don't know. I think that's really important, that they look and know first without anyone announcing it. Because often we do have a little delay for the cord clamping, so we can do that delayed cord clamping at a Caesarean section as well.
Oh, okay.
Yeah.
Great.
So you can do that. Once we've cut the cord, normally the paediatrician is sort of standing just behind me, between myself and mum and partners on the other side. So I'll hand the baby to the paediatrician, and they'll often give mum some immediate skin-to-skin contact then, in terms of giving baby a kiss and a touch and all that sort of stuff. Then we do, as I mentioned, because theatre's cold, normally they do take the baby out of the cot, and dad can go over to the cot, take lots of photos, dad can trim the cord as well. And then they wrap baby up and bring over to mum for a cuddle. It's slightly awkward sometimes, because I obviously need mum from there down. So they've sort of got mum up there, but partner, midwife, anyone, if they're having trouble holding baby, can help. So at that point, if they sort of want to open the wraps a little bit, they can put baby on skin to skin. The other important thing to sort of mention as well, in terms of recovery, often just before we're finishing up, in terms of the surgery, midwife, dad and baby will go out to recovery. Because in terms of getting mum off the bed, we then have a bed in there and all sorts. So it's in terms of room in the theatre, we get those guys to exit, get mum onto the bed, cleaned up, and then out to recovery. Usually then when you go out to recovery, dad's out there and having a fabulous cuddle. And I think it's a really nice little bonding time for dad or partner. And they can actually, sometimes you go out there and dad's or partner's got skin to skin as well in recovery. So I think it's a really nice time for the partners, that just 10 minutes at normally all it is. and then yeah, mum normally then gets bub after that and can start to breastfeed in recovery as well, is another thing to mention.
Fantastic. So midwives and recovery staff won't worry at all if dad rips his shirt off? Good one. Or even if they wear it buttoned down maybe, and they can...
Whatever if they can think of it appropriate if they want to, but no. And you've got to remember, sort of theatre staff midwives, we're all used to, people in all sorts of states of undress. So, yeah, nobody's fazed by that.
Yeah, brilliant. So I'm just having a little look down here, just, again about a spinal. Can you move your arms after a spinal?
Yeah, absolutely. So you can move your arms the whole time. So it's really sort of from just under your boobs, really, in terms of there down is numb. So up the top, you got all feeling, all movement. Yeah, so that's why mum can hold baby, while we're still doing our thing and having our own little chat often, while we're finishing off the surgery. Yeah.
Okay. So you've mentioned a fair bit about what parents can expect in recovery, in the recovery period. So in recovery itself, you can expect to commence breastfeeding and you can have the skin-to-skin contact. Is there anything else about recovery itself that you think is worthy of mentioning?
Couple of things. Baby's normally weighed there,
Oh, yeah.
so you sort of get that information. And where I do most of my deliveries at St Vincent's Private, they tend to have a bit of a bigger separate area in recovery for mums and bubs. That sort of, just has that bit more room, and it's a little bit more private.
Okay, great. And what about after you've come out of recovery? Then we're going to talk about what can women expect. You've said before that it's often not as bad as what they think. What are the important things that you think women should know for, say, the 6 weeks post?
Yeah. So a common question is driving. And people think it's 6 weeks. It doesn't have to be. I often say to women, look, it can be individual for different insurance companies. So it's sometimes worth asking them what they want. But the main thing in terms of driving, it's not that you can't actually physically drive. What we are concerned about is your ability to brake quickly. So if you're sort of, potentially going to be in an accident if you don't brake quickly, that's the issue. And in terms of braking quickly, if you think about the movement you do with your leg, you use your tummy muscles. And that can just, in doing that, can give you a sharp pain. And if you then hesitate, that's the issue with driving. So usually it's most women after 3 to 4 weeks are probably safe to drive. But again, if you need to, you can always check with your insurance company. Yeah. And sort of along from that is, in terms of the abdominal muscles, I think a lot of women think we cut the abdominal muscles. We don't. The abdominal muscles sort of have two, if you can imagine a six-pack, sort of have two lines. We actually just separate that. We don't cut them. So it's not the muscles, it's more the sort of skin, and just if you sort of do things quickly in terms of getting pain when you do that movement.
Yes, so the incision is very superficial, but once you're down, into the muscle area, it's a separation.
Separation, yeah.
Okay, great. So are there many women who do come to you and say, do you know what, I just want a cesarean? Yeah,
that's a really good question. It's not very many. And my normal sort of way that I deal and look at that is ask them why they want that cesarean section. And is it just a fear of an epidural, or is it a fear of the pain, or sort of what is the reason they want it? I think it's an absolutely reasonable request, because you do see not such good outcomes in terms of, sometimes pelvic floors or tears with vaginal deliveries. So I think it's an absolutely fair request. I always go through the pros and cons of a caesarean section versus a vaginal delivery. And I give them written information about that and about caesarean section, so that it becomes an informed decision, which I think is really important that they understand that. The other thing is that if they want to have a caesarean section for their first baby, I sort of point out that please don't turn around and want to try vaginal delivery for the second, because it's actually riskier because you've got the scar on the uterus. So if you're going to try for vaginal delivery, it's best to try on the first one because we have a few more things that we can do to get labour happening if it's slow, whereas we don't always have those options if you've had a caesarean section already.
Okay.
If you need an elective caesarean for the first one for you know, a reason where you have to, such as a low placenta or breach, absolutely you can try for a vaginal delivery in the second one if you want. That's absolutely fine. The other thing I probably wanted to say in this conversation as well, because sometimes there is negative stuff out there about having a caesarean section, and sometimes women feel that they have failed, which I think is awful. Because if it really wanted a vaginal delivery and ended up with a caesarean section. And I really dislike that notion out there that it's somehow a failure. I like to think about and remind them what was the reason that it became pregnant. And obviously that answer is to have a baby and have a healthy baby. So I think sometimes we lose that perspective of what was the reason we became pregnant. And yes, everyone can have a different journey of how they get there, but in the end, that doesn't really matter. It's getting that baby is why we do all of this.
Yeah, and it's healthy mum, healthy baby, and that's in every way, isn't it? Not just physically, it's emotionally and mentally as well. And when women come away with a feeling of failure, mentally and emotionally, they're really knocking themselves around, and that's really sad, and something I'm very aware of can happen. So taking that whole did you pass or did you fail paradigm away will do a very good thing for women's mental health, I think, going forward into motherhood.
Yeah, and that's why, I think that's why we sort of called this positive caesarean section, because that's really what I do try and make it. It's a happy operation. You get a good outcome, you get a baby out of it. It's not like other operations that I do where we're just removing a tumour or, something else like that. It's a happy operation. So I really try and I think all theatre stuff do. It's a different feeling in theatre for a caesarean, because it's a happy operation, and, it is one of those lovely operations to do. Because you get something positive out of it.
Yeah, I could imagine the feeling in theatre is quite happy and joyful, and it's lovely to think that everyone else is enjoying it too. So, not just mum and dad are excited, but the staff as well.
Yeah, it's absolutely true. It is. It's lovely. Yeah.
So I've got just a couple of quick questions because we could talk for so much longer. But
no, it's been easy to get to sort of talk. Yeah.
Just to set that scene in theatre, do people bring their own music in?
Look, you can if you want to. You can try. It's often the anaesthetists that tend to control that. But certainly, if you sort of wanted to bring it, a little speaker on your phone in and have your own music, that would be okay. Yeah. Mm-hmm. Yeah. Some anaesthetists have their own music, and I do know one particular anaesthetist who, when he sees it's a boy or a girl, has a playlist for a girl and a playlist for a boy, which quickly runs through all sorts of girl power songs and then otherwise boy songs. It's always a bit funny.
So talk to the anaesthetist about that if you're wanting to go down that line.
Yeah.
Okay. I'd love to see that playlist. So, and what about doing preparation for caesarean birth? Do you think that it's a good thing to be doing something along the lines of mindfulness or relaxation skills to use in the operating theatre?
Yeah, absolutely. Yeah, you can employ all those things, especially if you sort of do have it, that feeling a bit of anxiousness leading up to it, because we completely understand it's a foreign environment for patients. They've never been into a theatre before. They're awake. There's a lot of stuff happening around them. So I think an important thing would be to just concentrate on the main people, which is the partner, the anaesthetist, midwife, and myself. Mm-hmm. Okay, because I can actually talk to them over the drape. So I think if you concentrate on those main people and sort of just leave the others as peripheral and they're doing their job but don't worry about them, that can help. But yeah, if you think you're going to be sort of a bit anxious, absolutely. You can use all those mindfulness things to sort of calm down. Yeah.
Yeah. Yeah. I think they're great skills for everything in life, but for birth, for all sorts of birth. It doesn't just have to be this idea of you only do it if you're going to have a natural birth, whatever that means to people, their own definition. So, yeah, I think that they're never wasted if people have gone and done those sorts of skills. Yeah. You can apply them to anywhere and any time you're feeling anxious. Exactly. I know I do. Yeah.
Yeah. Yeah. And look, one other little practical thing, in terms of preparation for a caesarean, if you know you're going to have one, if it's elective, is a lot of women we suggest, because the pubic hair, because that cut is quite low down, if you haven't waxed it, so my suggestion is to sort of wax a strip off the top, because if you haven't done that, then we actually do need to shave it, and it's sometimes it's often the midwives or the theatre techs do it, and they're probably not beauty trained, so it's an idea to sort of get that top little bit waxed off.
Yeah, and regrowth isn't such a problem.
Yeah, if you can delay that by waxing rather than shaving them, that's not a bad thing. Yeah.
Excellent tip. One more question that someone's asked me once, and I would love to hear your answer. Can people wear makeup to a caesarean for those shots?
Absolutely. You want to look your best, especially if you haven't had to go through labour and look a bit, disheveled. No, absolutely. Yeah, you can wear makeup. That's not a problem at all. Yeah. And in terms of photos, look, you do tend to get lots because, the anaesthetist midwife will take the camera or the phone and take lots of photos, and, photos of you cuddling baby with dad in there as well. I try to photobomb those ones sometimes just for a bit of fun. It's plenty of photos. So, go for your life and look your best.
This is so first world of me to ask this, but can you wear toenail polish, or do you need the fingers and toes still clear for checking perfusion?
No, you can. Yeah, that's absolutely fine.
Mm-hmm. Okay, well, I'm just looking at the time, and I know you've got people waiting to see you.
Yes.
So I just want to say thank you, because what you've shared with us today is just such valuable information. And I know that there's some real pearls of wisdom in what you've just shared with us that are really going to help parents feel more prepared and empowered for their caesarean birth. And I just want to really thank you for that.
No problems at all. Pleasure joining you. It was actually really good fun. It was the first time I've done this, and it was great.
Let's do it again. I'll talk to you after. I don't want to put you on the spot with yes or no answer. So, but what I would say to people listening and watching in today is, if you're wanting to contact Dr. King, you can head to the Melbourne City Obstetricians and Gynecology Group's website, and all the details will be found there, and we're going to list that for you by the end of today on the Birth Sense Australia Handy Contacts page, so just link on through. And I just wanted to say thank you to you all if you've listened in today. There's a couple more questions there we didn't quite get to, and what I'll do is I'll just send Dr. King an email and get your question answered, and I'll pop it on the Facebook page that we have, so you can just keep an eye out for that. And if you want to tag me, I'll tag you back so you can see that answer and not miss it. And look, I just want to say again, we just are keen to get the right information out there from the right people to you. So we'll be doing more of these interviews with experts and friends, and take care of yourselves, and I'll see you soon. Bye.